And that is the end of my section. Do we need to pause for questions, or?
It's up to you if you'd like.
It's up to you before I leave.
I haven't been watching them because I've been presenting, so.
Okay. I don't know where we're at.
I don't know where we're at.
Okay. Interactive complexity code. For mental health outpatient, 90791, prior authorizations is also applied to children. So yes, we answered that one. You do need to seek prior authorization even for children. I think I'm not sure I see the typo. I think I answered it previously that you cannot apply interactive complexity to every appointment. You just need to document why that service was interactively complex. The American Academy of Child and Adolescent Psychiatry has some pages on interactive complexity. It's actually posted to bh.medicaid.ohio.gov. That might help you with some of your questions about interactive complexity. So someone is asking if there is a break in the time that the patient is in an IOP group and the time they attend. Will they still be able to bill IOP for the day? How do you document the start and end time? Well, you need to document that they were there for the minimum amount of time required to bill IOP. We're not saying that someone can't use the bathroom, but you can't count like them in an individual service or them getting lunch or something like that as part of your IOP group time. They need to be receiving group services for the minimum amount of time. No, TBS is not billable for phone calls. So TBS cannot be billed for a phone call with a client or a significant other, only face-to-face. And what I said earlier was that if the service is allowed to be billable by phone, it will say explicitly that it can. Place of service 53 states you had to be certified by Medicare as a CMHC. If not, you use place of service 11. That's not a Medicaid rule, but if you feel more comfortable using place of service 11, that's fine. I have a provider who is an LPCC and sees patients in the office. She currently only bills 90787 and 90791. Does she need to change anything? Yes. 90797 is not a billable code anymore. And 90791 is, but it has a limit of 1 per year per patient per agency. You need to go to the code chart, look at the LPCC tab, and see all the codes they can bill. It'll be profitable for you as a business to understand that they can now bill all the psychotherapy codes, psych testing, day treatment, extensive amount of other services. So I would not just limit them to 90791. The hospital Medicaid email is hospital_policy@medicaid.ohio.gov. Is there a place, website, or number we can call to see if we are registered with Medicaid and affiliated with our agency? Can we check to see that they are complete for our agency? Whoever has access to your MITS portal needs to do it from there. You log on to your MITS portal and you look at your group members, and it says every provider that is enrolled and affiliated with your agency. If you have questions about certification with mental health and addiction services, you can contact them, their office. Yeah, it's on the website. ODM still refers to QMHS and CMS, but I was under the impression that OMHAS now has combined those individuals under one category called QBHS. So QBHS under the new proposed rule from OMHS could collect urine. Correct. Incorrect for Medicaid purposes. We still have them as separate provider agencies, 84s and 95. They're completely separate. So the practitioners are separate too. So for Medicaid billing purposes, It's a QMHS for mental health, and then there are CM specialists on the SUD side. Remember that the Ohio Mental Health and Addiction Services rules are agnostic to payer, so they are applicable to many different payers in Ohio, whereas for Medicaid reimbursement, you have to follow our rules. Can a facility licensed by the state for SUD-only services provide co-occurring treatment services? For Medicaid reimbursement, if you are enrolled as a provider type 95 SUD provider, you can only provide the SUD services. If you're enrolled as a provider type 84, you can only provide the mental health services. If you are both, you can provide both, but you need to bill them under their separate provider types. Can a diagnostic assessment and therapy be billed on the same day, back to back? You need to look at the NCCI edits on that. Can you clarify your IOP example of a patient who is sick on the third day? IOP group code can only be billed if the patient actually receives more than 9 hours of service within the week. Correct. No, as we were saying, a person who's in the IOP level of care is in that level of care because they meet the requirements for that level of care, which means that they need more than 9 hours of services a week. However, if they miss a day, that doesn't mean that they are less in need of that level of care. So they could still be in the IOP level of care. You just don't bill the group service if they did not come to group that day. How easy is it to change from a provider type 95 to both 95 and 84? You need to go through certification with mental health and addiction services for mental health agency, and that's how you get enrolled with Ohio Medicaid as a provider type 84. And they'll be issuing more information on mental health certification, so I'm going to skip those questions. As Doug said, you'll be getting more information on it. So we keep hearing that we may bill a 99215 instead of a 90792 for a psych eval or first visit with a prescriber. Is this correct? You need to bill the code that is most appropriate with that service. A 99215 is the highest level of evaluation and management service for a established patient. So you couldn't use that code for a first time meeting with the prescriber anyway, but you need to understand the difference between a psychiatric diagnostic evaluation and a evaluation and management visit with a physician. So we're getting a lot of questions on what can be billed together on the same day. I'm going to skip those, and I'm actually going to refer you to our website, bh.medicaid.ohio.gov. On the manuals tab, there is a document under IT resources that lists all of the codes and what can be billed on the same day and how they interact. So if you have a question on what two services can be billed on the same day and reimbursed, you need to look at that chart. So for anyone who can't hear us, we do have a lot of people who can hear us. It may be that you have muted us on your end, but we are telling the audio, and I just realized that even if you can't hear us, you wouldn't have heard that announcement anyway, so probably not useful. I just want to assure everyone that we are projecting and recording. So if a patient comes into the office for withdrawal management, ambulatory detox, what is the code for a physician-based services? The RN and LPN code H0014 is for their services. Other individual services would be billed outside of that as permitted. On slide page 47, example of 120 minutes of crisis psychotherapy reported. Do you use 90839 for 60 minutes, use 90840, and again 90840 for the additional 30 minutes, again when reporting via electronic paper? So I think you're asking about how you bill, and yes, the example is laid out how you should bill it. 90839 for the additional 60 minutes, and then 90840 is for each additional 30 minutes. So if you've gone 120 minutes, you would add 90840 twice. Can the trainee provide psychotherapy in the client's home while the supervisor is in the office, and it can be considered direct supervision? No, that's general supervision. If you read the definition of both, general is available by phone, direct is immediately available and interruptible. So if someone is in the home and the physician or the supervisor is in the office, that's considered general supervision, and you would need to bill it that way. Can a BSN provide direct supervision for clinicians with degrees below them? We don't know. RNs cannot provide supervision and be the supervisor on the claim because there are no people that they can supervise that require that supervision on the claim. Can LPCC supervise social worker trainees, LSWs, LPCCs? We refer back to the licensing boards on that. Direct supervision. Supervisor can be interrupted and immediately available. Can that be available by phone or only on site? Only on site. As we said, available by phone is general supervision. Can you clarify that 50% of the session does not require the LISW to be present in order to bill under their MPI? I'm sorry, I don't understand that question. You would only bill under someone's MPI if they provided the service. If you're referring to supervision, they don't need to be there at all, but they need to be directly available and immediately available and interruptible if you're going to bill them as the supervisor. In regards to supervision for a case, can some claims be submitted under general supervision while others are submitted under direct? Yes, that's the idea. You would need to submit them on different claims, but yes, if someone is under direct supervision one day, but under general the next day, they would need to be billed differently because they're going to get different payment rates and it needs to match the actual activity that occurred. For duly licensed providers, a provider is an LISW and an LICDC. If they're enrolled as an LISW, do they also have to enroll under the LICDC role? We cannot, Ohio Medicaid cannot have people enrolled as multiple different providers. We are working on different policies in regards to when managed care carves in and if that is something that can be accompanied there, but we can only accept one NPI per provider type. So in the case of an LISW and an LICDC, you need to pick the one with the largest scope. You're going to want to pick the LISW because they have the ability to do mental health and SUD services. The supervisor MPI that needs to report it in the supervisor field is actually the one who provided the direct supervision for that service on that day. For add-on codes like the 90840, you still need to use the practitioner modifier for that code as well, correct? Yes, every code that you bill needs to have a practitioner affiliated, whether via rendering MPI or with a modifier. Would you please define a master's level or bachelor's level trainee? Well, it's just someone with a master's or a bachelor's. I guess I'm not quite sure what the question is. If you look at the workbook, it talks about all the different practitioners that can build codes. Okay. We have a new LICDC starting in mid-June from out of state. Her license was just approved, but it'll be enough time to get her registered. You will need to submit it as soon as you can. If it's not ready by July 1, that does not mean that you are going to lose those claims. Medicaid backdates back to the date of back to the date of license. So if your LICDC, you submitted their enrollment now and their enrollment became active as of July 15th, everything that they did between July 1st and July 15th is billable. You'll just need to submit the claims after their enrollment is processed. The minimum daily requirement to bill the SUD residential per diem rate. There is no minimum daily requirement. The assumption is that they will be there. They need to meet the level of care and that they will be there all day because they are staying there, and that you are providing all the services that that person needs in that day. An RN or LPN can only bill for services that have an order by a physician. So that's just a requirement for all billing for RN and LPN. Just to clarify, an LSW billing psychotherapy under general supervision will not have to list the supervisor LISW as the rendering or supervisor on the claim. That is correct. Under general supervision, you will just list the modifier and the billing MPI. You do not need to put anything else. If you're looking for the provider affiliation list, just go to our website, bh.medicaid.ohio.gov/manuals. It's on that page. When you are billing a large counseling group, does the second staff person have to have the credentials to bill? Yes. So if you are providing a group and you have one LICDC and one CDCA, that's completely fine. They can both provide that service and bill, but you couldn't bill it with someone who is not eligible to provide that service. If I, as an LICDC, participate in a group of 24 clients and my co-facilitator is a CDCA, what rate do we bill at? You bill at the highest level credential. Is there a specific billing code for a nurse conducting a health history exam under SUD? All of the services that a nurse can provide are on that tab with the nursing codes. So they will likely bill it under T1002, which is their RN code. Can an RN or LPN see client first and diagnose before seeing a doctor for an outpatient setting? An RN or LPN do not have the scope to diagnose. If a counselor or CPST go to the jail to provide an outpatient service, can Medicaid be billed for this service? No, Medicaid does not pay for services in jails. For 90791 and 90792, the limit is one of each code per person, per billing provider, per calendar year. Can a licensed provider who typically provides therapy provide CPST groups? A licensed provider can provide CPST, and I would just encourage you to go to the code chart and click on the tab to see what they can all provide. Who can tell us where the denial code needs to go on the bill? You can contact our Medicaid ombudsman, and they can help you with that. Just call the provider hotline. Dependently licensed and trainees generally are not paid by commercial insurance. Do we still need to bill the insurance? If it's one of the codes that has to be billed to commercial, which is one of the codes that has to be billed to Medicare, yes, you do. And then you would get a denial code, and you would bill it to Medicaid. With a lower licensure clinician, should the MPI on the claim be the agency's MPI if not billed under a supervisor? If it's provided by an unlicensed staff member under general supervision, you leave the rendering blank. You put the billing MPI in the billing field, and you put the U modifier to represent the unlicensed clinician. If it's performed under the direct supervision of a supervisor, you still leave the rendering field blank. You put the supervisor's MPI in the supervisor field. To bill for ACT, do we have to be a part of an agency, or can this service be provided out of a provider practice? It's only for community behavioral health providers, 84 and 95. H0048 is not listed in the provider manual for peer recovery supporters, but it has a rate in the workbook. We'll check on that. So I did want to talk about this one. It says we clarify whether for a group counseling session, we might have 26 people in the session, 3 counselors, and we can bill all 26 individuals under the one counselor with the highest licensing. That is correct. However, an example, you said if we have a doctor level leading or in the room, all the claims could be coded with this provider MPI. If the doctor level is leading, that is correct, but simply being in the room does not allow you to bill under their MPI. They need to be the leading the group or co-facilitating the group. They have to have provided the service. Could you be more specific about when to use place of service 99? In the manual, it says which codes can be used under place of service 99, which we've defined as community. The link in the presentation to the NCCI edit takes me to page not found. If you Google NCCI edits Medicaid, it should come up, and we'll check that link. Is there a minimum number of contacts a month for ACT clients? There is not a minimum, but we do expect that you are handling all of the needs of the client for that month. Are CNPs included with the APRN group? Yes. For young adults, does a young adult need to first receive services from an IHBT team before they can be accepted and approved through an ACT team? They won't overlap. IHBT is for youth and adolescents, and ACT is for adults. What codes are used for case management? Well, there are multiple codes that have some case management aspects on the mental health side, TBS, PSR, CPST, and then there's a code called case management on the SUD side. So agencies can be paid for crisis, even if someone is enrolled in an ACT team, but that is the only service that other agencies can be billed for, can be paid for while someone is enrolled in ACT. So this person's asking about disenrollment from ACT. The agency that is the ACT team or the patient has to do the disenrollment, and they have to ask the agency that they're enrolled with to do the disenrollment. A third party, another agency cannot disenroll someone from ACT. So it's your responsibility. If someone shows up and they're on an ACT team, you can find that out in MITS, and you should be contacting their ACT team to get them reaffiliated. Have you covered peer support services yet? Yep. Please look at the manual and the code chart. It's all there. And we're about to talk about, and we already talked about peer, right? Okay.
Covered it before. No, first thing.
You can find out if someone's in a lock-in when you look in MITS or when you're checking their eligibility. You need to look for documentation requirements, including supervisor in 5160-805. Ohio MHAS is aligning their rules with the ASAM levels, so that's what you'll need to follow. Everything that interactive complexity can be billed with is included in the definition on the code chart. At this time, we're not anticipating any delay of behavioral health redesign and are moving forward with July 1, and we recommend that everyone is ready to also implement July 1. General supervision is available by phone. Direct supervision has to be in person. If it's not listed in the manual as an allowable place of service, then it's not an allowable place of service. there's open enrollment for providers to become, there's no open enrollment for Medicaid providers. You maybe think, oh, I'm sorry. I don't think there's open enrollment. There's not open enrollment for Medicare providers. You may be thinking about open enrollment for Medicare recipients. They might have something like that, but not for providers. You should just email, if you have questions about outpatient hospital, you should just email that outpatient hospital box. Someone there will get it and they can have a call with you to talk through all your options. CPST can still be provided via telephone, but the GT modifier, if you look at the definition of it, is not telephone, it's secure video conferencing. So that's what it means in the manual. When you see the GT modifier, it means secure video conferencing. It doesn't mean telephone. How is supervision handled during supervisor vacation? You need to just report the supervisor that's actually providing the supervision. For questions about what an LICDC can bill, please look at the manual and the code chart. What can be billed on the same day is on our website, bh.medicaid.ohio.gov/manuals. You should just be familiar with all of the documents on that page. Can an advanced practice registered nurse provide order for med-som, or does it have to be a physician? An advanced practice nurse can order services for an RN LPN. We don't cover the med-somatic service anymore. All nursing services have to be done under a doctor's order. That's a nursing board requirement. RNs and LPNs cannot operate without an order. If you want to know when you can use the GT modifier for secure video conferencing, look at the manual. This whole type of bill for all of this whole presentation is about a $1,500. This has nothing to do with UB. We're talking about community behavioral health agencies, 84s and 95s. LSW can't be the supervisor on a claim because they don't have an MPI. If a practitioner is in a master's program but has not completed it, do they bill as a master's QMHS or as a bachelor's? They need to bill as a bachelor's because they do not have a master's as of yet. IHBT, if you have questions about hospitals, you need to message that hospital box. If you want more documentation on any of the coding matrix, you can go look at the website. All right. You don't need to use a modifier for telephone services. H0016 is not a covered service anymore. If a physician orders a service, that does not mean it's medically necessary. You need to provide medical necessity documentation. Can an LPC with a master's degree bill Medicaid without supervision? They're under direct supervision. And yes, we are recording this presentation. And I'm going to stop answering questions now.
Why don't we continue on with the presentation?
And now back to our regularly scheduled programming, if you will. So thank you, Cicely, for getting us caught up through those questions. A number of them are repeats, so you'll pardon us if we don't address every single question, especially if we've previously addressed it, maybe once or twice. So our next section is on care coordination. So what you see here is a heat map produced by a consultant agency to the Department of Medicaid looking at behavioral health spend claims and medical spend claims. And what you see is we actually have 3 areas marked. The top right, bottom right, and top left, for want of a better term. And these are areas where patients can be identified that would likely benefit from some level of care coordination. Currently, we have care coordination embedded in some of the community-based services. We have care coordination embedded in the managed care plans. And Medicaid is bringing online the CPC, Comprehensive Primary Care program. I think at last count there were like 96 practices enrolled, which also carries a level of care coordination. So, but going through the work of understanding how care coordination intersects, that's why we mark these 3 areas. Folks with high medical spend, high behavioral health spend, that's the top right, are likely to benefit from care coordination, probably managed mainly through the Community Behavioral Health Center. The bottom right are those individuals with high medical spend but low behavioral health spend. Those individuals are probably best managed at that point through the comprehensive primary care or through the medical. Then you have our individuals who have low medical spend but high behavioral health. Again, that's probably an area where it's best to have the behavioral health doing that work since the bulk of the services are in behavioral health. I also point that one out because sometimes when you look at these, you may try to distinguish adult versus kids. Adults are probably more likely in the medical spend and behavioral health, the 2 on the right. Kids potentially could show up more in this left one because of the low medical, high behavioral. So we've kind of got a pretty good heat map here showing the patients that would likely benefit from care coordination. That being said, here is the picture or vision, if you will, of accountability for care coordination as we move forward. I mentioned managed care. We have talked about what we call our qualified behavioral health centers. Back in April of 2015, a little more than 2 years ago now, we took an opportunity through the core team to go through looking at, issues or models related to care coordination. We had models 1, 2, and 3. I won't rehash that for anybody, but if you're really interested, I still have all the documents and can send them to you. The system landed on model 2 commitment, and the state agreed to move forward with that between Medicaid and MHAS and the Office of Health Transformation. What that model had in it was care coordination managed by qualified behavioral health centers. That's why you see that down there in the bottom left. And then under the comprehensive primary care, the CPC program, care coordination is managed through the primary care entities. More can be found on Medicaid's website if you're interested in looking at that. That's the medical home model that Medicaid is bringing up as we're talking. Again, Medicaid managed care has some embedded in it, but the concept here is actually to get care coordination as close to the patient as you can. And we also envision that the Qualified Behavioral Health Center and the CPCs would be working and having mutual accountability, especially when there's some financial incentives to have that level of an arrangement there. So there's a lot of work underway here. We will be sharing it back with our work groups, so you'll see additional information as we move forward in the care coordination arena. Rule updates real quick. We've talked about it. Cicely can rattle off pretty much all of them from rote memory at this point on the Medicaid side. But we mentioned that there's also the MHAS rules that are going through restructuring and implementation for April. So we've actually done this in a number of stages. Back in February, both departments worked on rule changes, and we went through an informal procedure, if you will, and that was shared with our benefit and service development work group. Commentary was received and changes were made. That's part of a public process. Then there was the Common Sense Initiative public comment period that was open from March 17 through March 31. Additional feedback was gained through that, and updates have been made and rules republished to meet our July 1 filing date. Rules are actually submitted and filed. That was on the 14th. Updates again were shared with the Benefit and Service Development Work Group all along. I believe on the Medicaid side there was something in excess of over 300 comments, if you will, on the rules at that point in time. So there was a lot of response from the field. Oftentimes there were very similar comments, so those have been updated. I believe even as of this Friday, that's when some of the most recent updates were pushed through on both the mental health and mental health and addiction services and Medicaid rules. Not this coming Friday, but last Friday. Thank you, Mary.
Friday the 19th.
Thank you. So if you need those, that's why we keep saying go to the Register of Ohio, and you can search for those rules either by number or filing agencies, and you can get those rules. There were public hearings, May the 15th and May the 17th. JCAR hearing is coming up end of this week. Next week.
The 30th.
Yeah, May the 30th. And then the rules are set to be final filed with being effective July the 1st. So we are reminding folks we are on track to have our regulatory structure in place to make sure we are supporting this come July 1st. So stakeholder resources. Throughout the presentation, we've talked about a lot of change. So in addition to agencies and state going through this, individuals are coming along with the changes too. So we've got some information out there to help with that. So Medicaid enrollees can always call the consumer hotline. That's the 1-800-324-8680 number to speak to a person to seek help or answer to their questions. Medicaid recently brought on their beneficiary ombuds person, which is Sherry Warner here. That's her direct phone number, and that's her email, where individuals can get in touch, and she will help them with whatever inquiries they have. On the MHAS side, we have our client rights and advocacy resource that people can reach out to. They do all the time. In fact, I get calls routed to me from it. So if an individual is struggling and needs some assistance, there's another doorway for them to come and seek help. NAMI also has a helpline, National Alliance on Mental Illness. That's there. The board association, the Ohio Association of County Behavioral Health Authorities, actually has their board directory available. People can contact the local boards for assistance too. If an individual needs help regarding managed care, they can come in through the consumer hotline again. And then there's our myriad of specialized recovery services resources, the three, if you will, recovery management entities there, phone numbers and direct emails to get in touch with folks there. So there are many ways. We don't consider there any wrong door, and we all go through what we can to help anybody, especially if they need some assistance with this. Workbook updates. I will not go over all this because, as Cicely mentioned, she's been working to make get a newer one posted out there shortly. She does a yeoman's job keeping this thing up to date, but unfortunately there are a lot of links, and sometimes I believe her term earlier was it does get a little wonky and we have to reissue it to fix something. And we appreciate it. If somebody sees something wrong, let us know. We're not offended. We know that there are times where it's not quite correct or not everything is linked correctly. So if you do see something, feel free to contact somebody, and shortly we'll make sure folks know when there's a new one out there. Quite frankly, this one is just where we bumped up the payment amount for urine drug screening by another $3 to help cover the cost of overhead, if you will, associated with collecting a urine specimen, whether it's tested there on site through the Instacup, if you will, or sent for actual laboratory testing. Place of service, we've mentioned this a few times, that hospital and 99 other or community were not in the recognized list of places of service. We have brought them back. Please pay particular attention to the charts in the provider manual. That is where you will find whether Medicaid will actually pay when the place of service is reported. Those are at the tail end of each of those charts. I won't go through 99, but please pay attention. Here's the definition of 99 being community. Technically, the HIPAA Code 99 is other, but for Ohio, we've given you guidance on community and when that's appropriate to use that. You do need to keep in mind, again, a caution. You cannot use place of service 99 to circumvent, if you will, the incarcerated prohibition. Documentation. Both departments fully support the use of EHRs, including structured drop-down or checklist options that support individualized clinical documentation. Cloning, if you haven't heard that before, it's actually a term. Think about it as cut and paste. You cannot do that. Individualized clinical documentation needs to be exactly that, individualized. And if you want to see a little bit more about it, you can go to this link here from CMS. It's some program integrity information about EHR, use of EHRs and federal information about that. Okay. We have mentioned bh.medicaid.ohio.gov/manuals. This is actually a shot of that website. Looking at it, I know it's a little out of date, but we show you here exactly where you can go to get to the IT resources we have referenced. There is a Excel file, Services Billable to Medicare, that contains all the codes that can be billed to Medicare and covered by Medicare. And I believe there's a second tab that has all the codes that do not need to be billed to Medicare because they don't cover them. There's a supervisor rendering ordering fields document. It's very nice. It shows by service code groupings, if you will, what needs to be in what field when. I don't know a better way to say that, but there's a services crosswalk. It's a large XY table so that you can find any service across or up and down and then look at all the other services that it interacts with. There is a legend in there so you can understand what the nomenclature means that's inside the cells. There's another similar one, but it's very specific to ACT and IHBT. I believe Mary mentioned earlier you have to keep in mind that when these are lock-ins, that other agencies may not be able to get services paid when individuals are either with an ACT or an IHBT team. There are diagnostic code groups. I think it's about 6 or 8 groups, and you can see all the diagnosis codes that are in those groups that are associated with the services there. There's a limits, audits, and edits document that's been used a lot to communicate with the MITS vendor on Ohio custom limit audits and edits. We don't duplicate NCCI edits in there because those are nationally managed, so we don't have to put them in. They're just part of the NCCI engine. Then there's also an EDI IT question and answer. There's an EDI IT work group, if you're not aware, led by Joan Schlagheck, and hopefully I got her name right, and Nicole Small from Medicaid. They meet, is it weekly now? What, bi-weekly? And they document the Q&As there and post that out for folks to see. Right. File testing. We are open for file testing. There are a number of providers who have worked either directly as their own trading partner or through a vendor to test files. I believe it's gone very well from the feedback that we've received from those who have begun testing. Keep in mind, testing is open 24/7, so if somebody really would like to test a file at 3 o'clock tomorrow morning, you're more than welcome to. This is getting everyone lined up for go live. The MyCare plans are working on their timelines for testing, all in preparation for our July 1st go live. So a little bit more on the testing. There is a rapid response team, so there is literally a room over at the Department of Medicaid with phones and computers and large visual aids up on the walls where entities that are testing files can get in touch with a live person to ask questions or help understand how to interpret the responses that they're receiving. I believe we're getting ready to release a MITS-BITS update today on this. I would also like to note that we are coming to, this is the Memorial Day weekend, so the rapid response team will only be available through 4 p.m. this Friday. It will not be available Saturday, nor will it be available Sunday or Monday. It will open back up Tuesday morning. So, staff are able to take advantage of the long weekend themselves. It doesn't prevent a vendor from testing. You just won't be able to get in touch with a live person through the rapid response team from 4 o'clock this Friday through Tuesday morning.
They can leave a message, and if folks are testing this weekend, feel free to leave a message. We can monitor those messages remotely, and if you need us to get back with you, we can do that. So if you do want to get work done on testing this weekend, just go ahead and leave a message, and we'll get back to you.
As I said, I believe we have another MITS bit, so if you're registered for all that, more additional information on that. These just are the times where you can call in. It's generally 7:30 to 7, Monday through Friday, and 8 to 1. Okay, for July 1st, this is kind of the last set of guidance here to get you to July 1st. Make sure that your practitioners are enrolled, those that need to enroll, the LISW, physician, etc. If you haven't done that, you may have a little challenge getting to July the 1st, but you still need to go ahead and do that. So enrollments for practitioners, they need an NPI. They need to do the enrollment through MITS. Respond quickly if you get a contact from Medicaid. A lot of times something wasn't actually attached to the application, which can delay it. And then once it's approved, make sure that the person is affiliated with the agency. It was mentioned earlier that to check that, you would have to log into MITS using the agency agency information to log in, and then there's a way to look at all the individuals that are affiliated. I don't believe the individual can do that for everybody, can they, Mary?
Sorry, I was reading questions.
I was just letting them know that to look at the affiliations, they actually have to come in as the agency to be able to see the affiliations, correct, not the individual.
Correct.
They can only see their affiliation, I think.
Correct. You would, whoever has access to your MITS portal, to that function, it would be your MITS administrator or anyone to whom they have delegated that responsibility, can go in and just look under the group member panel, and that way you can see which practitioners are affiliated with your agency.
Okay. Again, for those individuals who can be Medicare, you need to get them enrolled with Medicare. If you're seeing a Medicare population, caveat there is there have been a number of children's agencies that said we employ those practitioners, but because they're kids, we don't generally see Medicare patients. That's fine. They don't have to enroll if the population they're treating isn't Medicare. So IT, we just covered. Make sure that you're testing either directly if you're your own trading partner, or keep tabs on your vendor who is doing the testing to make sure that they're accomplishing that. We don't actually determine from the state side when a vendor has completed testing. That is a lot up to them to make sure that they're comfortable with the results they're receiving. So I would encourage you to really make sure that you're in touch with your vendor on that to understand what they are testing, and when they say that they're ready, what they actually mean when they're saying that to you. So then work with all your staff too. We appreciate everybody attending the webinar today and hope it has been informative. We do plan to post the recording. We did record it, so then I will have the challenge of making sure it's converted and we can get it out there. We are going to keep the log of questions. I'm not sure we have decided 100% that we'll answer them and post them up there, but we hope that we have been responding to them as we've been going. Okay, this is a lot of change. We've been out working with you all in the field with the work groups. In fact, we've got extensive lists of agencies, individuals, the work groups that we've been holding for the past 2.5 years. When you do something of this magnitude, we will be monitoring the outcome. So there are short-term and long-term objectives. We want to make sure that there is an adequate provider network in the short term. We want to make sure that people are able to access and receive services. We will be watching the claims payment and denied kind of ratio. You can't think of it as, well, if all these denials come through, it's not working correct. There's a lot of times where denial is the right thing. like we mentioned, if there's misuses of modifiers or coding with practitioners that can't use certain codes. But we will be looking at it as in terms of paid and, denied claims, and just making sure that there hasn't been anything going amiss. So far, the testing hasn't demonstrated any of that.
Testing's going well.
In fact, it has demonstrated that, we've provided some assistance so that some of the vendors would understand some of the changes and things that they needed to realign in their systems. So longer term, you would look at things like people served. We want to make sure that folks are still able to access and receive needed behavioral health services, including the new services, like we mentioned, ACT, IHBT, peer recovery support, SUD residential as per diems. So just monitoring that over time, the premise being we brought the new high need services online for the folks that need them. So we want to make sure that they are receiving them. I think, Mary, you mentioned, around 20 agencies in the ACT world right now. IHBT, I'm not quite sure of, maybe a few less.
It's a few less. It's more like 10 so far for IHBT.
And SUD residential will begin getting loaded up here shortly there. It's not the same because you don't have to go through a fidelity, but we do have to make sure that you have the right provider type connected. And then obviously overall looking at system and service line spending. Just something you do. You monitor the finances to keep your finger on the pulse of the system, if you will. Not that we haven't mentioned it a few times, but bh.medicaid.ohio.gov is out there. I don't even remember when we actually brought this up, but I'm going to say it's been probably 18 to 24 months at this point. We've had it out there. We will caution folks, I caution folks that you can find some of our older information still on the website, but the further back you go, the less accurate it is. So that's...
Always look at the most current version of the manual, the workbook, etc.
Yeah, so you can go there. We encourage folks to sign up for the BH Redesign newsletter if you haven't. And at the bottom left of this slide, there's actually a spot on the MHAS website where you can sign up for our BH Providers listserv. And we do tend to send things a lot of different routes just to get information out and in the system. So you may receive things multiple times, but that's better than not receiving anything at all. So we do try to communicate a lot of information targeted. I think our MITS today, we are like 40 days from go live. So, all right, we will go back to questions. All right.
This is
ODATA supplied a form that categorized patients by levels. Having the history on the ODATA side, we did have the ODATA's level of care protocols. Those have not been used for about a year, part of the combining of ODATA's and ODMH. From our certification side, we dropped the proprietary system, albeit very similar to ASAM, but have moved over to the ASAM criteria. We don't require forms ourselves. We don't require providers to use the American Society of Addiction Medicine Continuum product, but you are responsible for utilizing and applying the ASAM criteria. The rules filed with JCAR do not include the 100% reimbursement rate for TBS PSR over 90 minutes. That's when it's not provided in the office or the CMHC. The slide shared this morning is correct. When will the workbook be final? It's pretty much, you need to consider it final when we issue it. I don't believe we are apt to make any more, pardon the finger quotes, high-level policy changes at this point. So we would expect that you would begin using any and all version that you had. Recommendation, make sure you get the most recent one because that has some of the clarifications. Sometimes it's a simple, we missed putting something in because there's a lot of materials that we're handling. When will the 837 companion guide be available?
The IT resources. Yep. There is a requirement that the 837 guide not be formally issued and final in its final form until after go live. So don't wait for that. Look instead at the IT resources page on our bh.medicaid.ohio.gov website, and you can get all of the information that you need there regarding EDI file loops, segments, and coding and composition. Rules, understanding there isn't a per diem reimbursement that would support crisis stabilization units in the community. Is it ODM and Ohio MHAS's opinion that individuals should be stabilized in their own residence until they decompensate to the point where hospitalization is required? No, that is not our perspective. I think we are giving you clinicians with a clinical scope of practice a series of tools and rates to perform crisis stabilization and crisis intervention services. Please take a look at the coding chart and at the manual for all of the services that can be provided for crisis services. And then when the crisis has been resolved to the point that the person is not in danger anymore, then there are other services that can be provided. We have never provided a per diem reimbursement for crisis stabilization units from Medicaid. So just please familiarize yourselves with the services that can be performed and billed for crisis type intervention. I'm trying to find the most recent version of the rules. Go to the Register of Ohio is the best place to find the most recent version of the rules. And OAC Chapter 3793, I don't think we have anything left in 3793. That is the chapter that formerly held the rules for the Ohio Department of Alcohol and Drug Addiction Services, which hasn't existed for 2 years now. So don't go looking there. Look at the Register of Ohio. You're going to want to look at 5160-27 and 1 through, I believe it's 12 or 13 for the Medicaid rules, and 5122-29 are the chapters where mental health and addiction services rules are posted. You can search by rule number, you can search by agency. Go to the Register of Ohio and you can find the rules. Does a CDCA or above need to monitor the drug screen as the client provides the sample in order to bill the service? Doug?
When obtaining a urine sample, yes, you still have to do a chain of custody to assure that it doesn't get adulterated during the collection. And yes, generally one of our practitioners, you can't have a peer or a trained other, so yes, you do need to have an actual SUD professional with that in order to bill the collection code, which is what that really is in the future, since we pulled the whole lab part out and now the labs will be billing directly. So yes, you still have to assure a chain of custody to assure that the specimen is not tainted in any way, shape, or form. Place of service 23, hospital, emergency room. The slide said it will be allowed for crisis, but CPST allows for billing to help coordinate admissions and discharge. We'll be able to bill CPST if the CPST staff is at the hospital.
Well, we've changed our policy, and that was in the slide deck, on allowing services to be provided in the emergency room. So go back and take a look at the slides in this deck that we just covered earlier on that policy change. When will the final version of the provider manual be released? It's up there. As we said earlier, just check and make sure you're looking at the most current version of any of the resources at the bh.medicaid.ohio.gov website. We currently use location 56, Psych Residential Treatment Center, and Public Health Clinic 71, which aren't on the list of locations. Would 99 be a reasonable substitute? No. There are many other choices. I don't believe that either of these are acceptable places of service for the benefit package that's going in place July 1. So do take a look at the places of service. I would think that if you're performing service in an office, you might choose the Community Mental Health Center. You might choose 11 office. Take a look at them. 99 is reserved for a place of service that isn't covered by one of the other places of service. If a service is allowed by point of service codes, I think you mean place of service codes, provided by an allowed clinician to authorized client, can it be provided out of state? For example, providing linkage to a social service agency that is just across the state line for specialty services. So I guess I would point you to the manual in terms of looking at the allowed places of service. You would not want to choose an out-of-state place of service because it seems to me the service is occurring in-state. You're arranging service for someone else, and you would need to take a look at the requirements for services like case management that allow for those kinds of arrangements of service. Is Medicare billing a different site? We never billed Medicare before. If you are serving Medicare clients, you should be billing Medicare. If you're not serving Medicare clients, you don't need to be worrying about billing Medicare. If you are serving Medicare clients, you would need to contact Medicare and become familiar with their billing process. If we bill Medicaid through the MITS portal, do we need to do testing? No, you don't. And testing isn't open for the MITS portal. We're testing for EDI files right now. How can you validate that your trading partner has tested and been approved? Is there a list? You might want to call your trading partner and ask them about that. That's a service that you're buying from them, so give them a call. We have 2 providers who have not yet received their letters but are showing as affiliated to our agency. They were asked to resubmit their W-9 and did so in March and still have not received the letter. How's the best way to check on this? Why don't you send us an email at bh-enroll.medicaid or at medicaid.ohio.gov, bh-enroll@medicaid.ohio.gov. Or you can also comment on the bh.medicaid website. There's a contact us link on that website, and we'll get with you separately. Do agencies need to be certified through Ohio Mental Health and Addiction Services to provide peer support services? Yes, they do. And the peer support specialists also need to be certified. Does the website indicate this is final or is it still in draft? I would consider the documents that are on our website final. They're all going to say draft because we are tracking the changes as we move along and make policy changes. But as Doug said earlier, I think we're in the final stretch here, and we don't intend to make any other major policy changes between now and July 1. Did I miss clarification of 99211 should not be billed on the same day as 99213? If a nurse sees a patient, H2019 is to be used when appropriate. Is that correct on the crosswalk? So we do have a policy change that you would not bill 99211 and 99213. 99211 is the only CPT code that can be billed by an RN or an LPN. That's the lowest level existing patient office visit. You would only bill the 99213. However, if there is a nurse intervention that occurs during that visit, you can bill the nurse activity in addition to the evaluation and management code. So We provide psychotherapy in places in the community that don't seem to be covered by any of the POS, in the park, a court, or public setting. Is psychotherapy in these locations no longer covered? Look at the manual on the places of service that are allowed for the psychotherapy codes. I would just direct you to the manual for psychotherapy codes. We do have allowances for place of service 99, which is community, for certain of those codes. I'm not going to try and remember right now what's allowed for which codes, but please look at the manual on that. Can an LISW or an or LICDC NPI be the supervisor over CDCAs doing IOP groups, or no, not at all? Do you understand this question?
I think so, and I believe the answer is that if you have a CDCA who's facilitating an IOP group, and in your this person's example, that would be, I'm assuming, direct supervision, because they would be there on site. I believe that, yes, an LICDC or an LISW could be the direct supervisor or general supervisor, not to be confused with the credentialing board's clinical supervisor. So where's the information on the companion guide for the 837? I don't see anything under IT resources. You need to, I know some of it is in the slide decks, so it's not an actual companion guide by itself. That's, I believe, what Mary indicated. We won't actually be able to post that until July 1st. If a patient sees a psychiatrist for med management and a counselor for therapy on the same day, can both those services be billed on that day separately? They actually would be, because you have different practitioners and different services. In the presentation, it states that there is no benefit limit for crisis services, but there are NCCI MUE edits. That's correct. We state that there is no state-defined benefit limit, but that all NCCI edits do still apply. On the urine collection, is this for collection for an on-site lab? We use a cup that tests for 11 drugs. Is this billable? Yes, that would be the collection, and you're using the iCup for a point of service result. Slide 57 was the H0005 code without modifier omitted by mistake. No, because that slide is specifically about licensed practitioners. The physician, which is the AF modifier, the H0005 code has always been there for the unlicensed practitioners. So it was not omitted by mistake, but that slide is specific to licensed practitioners and the physician. When will testing for the MITS portal open for everyone? Again, manual claims entry is not subject to testing. EDI transactions are, and that is open to everyone right now. Do agencies need to be certified in crisis service in order to provide psychotherapy for crisis? Yes, Ohio MHAS still has a crisis services regulation. It's out there in the new grouping of certification rules, so please go take a look at them. Very specific health home question. It's been extended for 6 months. Is the same billing code used and the reimbursement the same? Yes and yes. I believe, can IHBT service be billed with a collateral when the client is not present? We'll have to come back to that one. If there's no companion guide prior to testing, what's the back date you'll allow for claims? Well, this will be subject to all claims July 1st, and the companion guide will be available July 1st also. Please keep in mind that it's interesting, the questions about the companion guide, because we are not changing any of the structure to the 837P file. In fact, we cannot do that. It's really data content policies, and that's why we've published the myriad of other information, the IT resources that are out there, The provider manual, I did mention earlier that in a number of those EDI IT slide decks, you will see language in there that talks a little more specifically about what goes in certain fields. So you can do an IOP group without a licensed person in the group. Can you clarify? Well, CDCAs are qualified to provide group counseling under their credential. So the earlier question about it seemed to lead us to believe that they were asking about a CDCA who's leading a group by themselves under direct supervision, immediately available and interruptible. If you have other additional questions about that, would direct you to the Chemical Dependency Board themselves, but it's our understanding that group counseling is within the purview of a CDCA and always has been. Does the client have to be present for psychiatric assessment? It is often beneficial with children to first meet alone with the parent. I apologize, but you're walking into a number of different things. If the client has not been some level of assessed, you don't have a patient. So anything you're doing with anybody prior to that is not going to be covered because you have not established a patient relationship. So in some ways, the answer is you need to be sure that you have assessed and engaged in the patient relationship first, because that's how you get the diagnosis, that's how you develop a treatment plan, and that's how you can begin providing services. And then subsequent to that, there are services that can be provided on behalf or through collateral contacts. Prolonged psychotherapy services. I see the prolonged code for psychotherapy for crisis. What about 90837 that goes 90 or 120 minutes? I believe that, please check your CPT book, but I do believe you can add the prolonged to the 90837. Yeah. We defer to CPT coding. So if it's allowable there, you can certainly use that. I believe Cicely mentioned earlier, there may be times where you might want to consider some variation of the mental health day treatment, but when it comes to CPT codes, we follow what's in the CPT coding.
To follow up on the psychotherapy allowable place of service, per the provider manual, 99 is only allowable with the UT modifier in crisis. That's correct. We do provide counseling in a park, community center, or library. It's often in lieu of the client's home for a variety of reasons. Will this no longer be allowed after July 1? There is a combination of codes that are available in the benefit package. Some of them are called psychotherapy, and those must be provided by licensed clinicians. Some of them are called counseling. Some of them are TBS and PSR and CPST. So if you look at the code and match it to the activity that is occurring, that's what you would bill. Some of them are available in place of service 99 and some of them are not. So keep looking at that manual. Is place of service 57 intentionally left off H0001 in the manual? I don't know what place of service 57 is. Do you, Doug?
Non-residential SUD treatment program.
Is it intentionally left out of the manual?
You can use place of service 11 in lieu of 57 for that.
It was mentioned in previous trainings that a prolonged procedure to individual psychotherapy may need prior authorization. Is this not true? It is not true. There's no prior authorization required for a prolonged procedure code. That's an add-on to a variety of the CPT codes, and it does not require prior authorization. What it will require is that you meet the criterion for prolonged service, and that's documented in your medical record. Are claims prior to July 1, 2017 to be billed as the current billing process? That is correct. July 1 of 2017, that date of service is when we will change from the current billing construct and benefit package and rates to the new construct and benefit package and rates. So at 12 o'clock midnight on July 1, 2017, any service that occurs at that moment or after, you will use the new billing code, the new billing mechanism and rates and benefit package. Any services that occur between or before then, you will use the current billing package. For location codes for youth on probation, is it appropriate to bill, say, a 90791, and would location code be 11 or 99? I'm not going to get into giving you advice about what code you should be billing for what activity with the youth. I will make a comment, however, with regard to the federal law with regard to inmates of a public institution. Just make sure that the youth that you're treating does have freedom of movement wherever you are treating them. If they do not have freedom of movement, if they are in a detention center, if they are in court, Medicaid cannot pay for their services, and that's according to the federal law. Expand upon the rules regarding supervisors regarding direct supervision of a trainee. Does it have to be the supervisor on record? Could it be any supervisor? Yes, it could be any supervisor who has the scope of practice to supervise the trainee and who is supervising the trainee on the day that the service is rendered. Is there a definition of resource that we can access to assist with defining appropriateness of prolonged service? I would refer you to your CPT book. If your agency doesn't have one, you should get one. Are there any issues with loading billables with UCC rates that are comparable to agency billing rates? I'm not sure I even understand this question. Do you understand it, Doug?
So I'll interpret it a little bit. An agency generally establishes their usual and customary charges. I believe that's the UCC rates. So yes, you should still do that, and that's what you charge. And in the case of a Medicaid claim, that's how you calculate the billed amount. And then MITS itself does the mathematics when the claim comes in, and it will pay the lesser of the charged amount or the Medicaid rate. So it's the lesser of. So yes, your current practice, you just need to continue it, and you may need to establish UCCs by practitioner level too. Last question again here. Just looked in the manual and don't see the criteria for prolonged service. Where would you find this? We have mentioned you need to look in the CPT book, the current procedural terminology book that you get from the American Medical Association. It's what your physician office uses to bill medical claims. And within that is where the AMA documents the criteria by service, which includes the prolonged service codes here. And with that, we actually have cleared all the questions that have been submitted.
So I did find an answer. We had a couple of questions about the EDI billing guide. And I checked with my colleague, Nicole Small, and she says that the information that you would use in place of the final EDI billing guide is in the most recent PowerPoint slides from the EDI work group. So if you go to the bh.medicaid.ohio.gov website and look for the slide deck from the April 26th meeting of the EDI work group. You will find that information in that PowerPoint slide deck.
So with that, thank you for attending today. We did record it, so hopefully we'll be able to put this out on the website for others to view. Hopefully it was informative, and thank you again for attending. Have a good afternoon.